Hello and welcome to the first episode of Ask the Expert, a series of podcasts featuring listener-submitted questions answered by a hemophilia treatment center clinician or other healthcare expert of interest. I'm your host, Patrick James Lynch. This episode's expert is Dr. Arash Mahajaran, who is a pediatric hematologist at the Children's Hospital of Orange County, California, and an assistant clinical professor at the University of California, Irvine. In a moment, you'll hear his responses to listener-submitted questions that we received through the Bloodstream Network's Facebook page, Twitter account, or through email to mailbag@bloodstreampod.com. Which reminds me, if you'd like to submit a bleeding disorders related question for consideration on a future episode of Ask the Expert, you can send it to us in 3 ways. Leave a question on the wall of the Bloodstream Network's Facebook page, facebook.com/bloodstreampod. Send a tweet with the question to @bloodstreaminfo or email mailbag@bloodstreampod.com. And with that, let's hear from our expert, Dr. Arash Mahajaran. So thanks again for agreeing to do this.
Oh, sure.
Okay, so our first question comes from a mother living in Kentucky. She says, my son is 16 months old, and we are finding that with each appointment, he's getting more and more anxious. In the waiting area, he will be okay, but as soon as we walk towards a room, he immediately begins to cry and get very upset. Do you have any tips for making these appointments less stressful for him? And she adds, we have a great HTC and his infusions have gone smoothly to date, but I can tell that that his anxiety is growing. Any tips would be appreciated. What do you say? I'm sure you see kids of around her son's age, 16 months, who are experiencing, various kinds of anxiety or discomfort with being at the clinic. How do you address that?
Oh, so it's an excellent question, and it has such broad applicability to really any young kid who's going to a physician, whether it's for vaccines or just checking weight or a checkup or of course going to an HTC. I think what we usually recommend for families to do is, first is trying to get the kid a little bit comfortable and familiar with some of the medical equipment. So a lot of times we encourage people to look for those small doctor's kits that are available at plenty of stores or Target or Walmart, places like that, where usually it's not too expensive. A few small plastic toys that resemble some of the medical equipment. So hopefully that gives them some sense that this is something they can interact with and that they could actually get their hands on as well. And so I think that hopefully helps at least with the equipment side of things. And then oftentimes we'll encourage families to let the kids bring those toys with them, and then they can kind of practice or play with the nurse or the doctor or whoever's there. And so for them, it feels a little bit more interactive as opposed to, someone that they may not really recall who's coming at them with strange equipment. If there's a particular toy or a favorite toy the child has or something of comfort to them, whether it's a blanket or a stuffed animal, anything along those lines, making sure to bring any sort of comfort items with them. So again, they start to feel a little more at home, if you will. We oftentimes say that bringing certain games or something that they haven't seen, in addition to their favorite, something that would be relatively new, so that there is something that catches their attention and hopefully they're a little more focused on something that's relatively new as opposed to just looking at the surroundings. And then, of course, when they see the parents are interacting in a friendly manner with the staff in the doctor's office, with the physician, with the rest of the team, then that always helps put the child at ease as well. So there are a number of different strategies and a lot of different things that work sometimes for some kids and sometimes not for others. And so there may be a little bit of trial and error that's needed. But certainly this is very common for lots of families. And then, of course, the other option as well is, trying to speak with some of the other families and asking parents of kids who might be a little older, say, well, what did you try with your kid? What worked? What didn't work? And then trying a few of those different strategies, and hopefully the kid will become a little more comfortable.
Great answer. Our next question comes as well from a hemo mom. Her son's a bit older. He's 11, and he has severe hemophilia B. She says that they're currently treating him with one product, but would like to explore some of the new longer-lasting factors. So I think we can determine from that he's not currently on a longer-lasting factor product. Her primary fear, as she states it, is that the switch will bring on inhibitors. Can you let me know if any of the new longer-lasting factor products have data on adolescents and whether any of their subjects experienced the onset of inhibitors? And I think we can extrapolate that to a slightly larger question about how do you navigate that conversation with families when a child is on a product and perhaps they want to switch to one of the newer products, a longer lasting product, but that fear of the switch instigating an inhibitor comes into the conversation. How do you navigate those conversations?
Oh, so it's certainly an excellent question, and I think it's a concern shared by everyone, all of the folks at the HTCs and in the different doctors' offices, as well as the patients and the families themselves. I think what we certainly try to do is first emphasize what is known and what isn't known. And what we know to date is that there doesn't appear to be an increase in risk of inhibitor with the new extended half-life products. But, of course, that's very preliminary. That a lot of these new products that have come out, most of the original research will have been done on patients who've been previously treated, who've had well over 100 plus exposures, if you will, to different factor VIII products or whichever product. So there is a little bit of a gap in knowledge there in that the exact risk isn't definitively known, and the thinking is there may be some slight differences between the different type of extended half-life. And that mainly comes from animal models and bench-type research where they look at sort of what happens with the immune system in a test tube, if you will, and it's yet to be translated directly to what happens clinically in real people in real time. But so we certainly try to emphasize in the initial discussion that it's not definitively known, but there doesn't appear to be a significantly increased risk with the new extended half-life products, and there's even some preliminary bench research that would suggest perhaps they are a little bit less antagonistic, if you will. Maybe that's not the best word, to the immune system, but maybe they don't trigger the immune system as much to develop an inhibitor. But that's certainly theory and is yet to be borne out in real-time research. And, of course, the research in previously untreated patients or folks who haven't been exposed to factor yet is still really yet to come out. And I think that's critical data that all of us are anxiously awaiting. So certainly there are some key challenges with switching in the sense that we know that it might reduce the amount of infusions. It might be a little bit more convenient, but there is some data there that would be a little bit, that is not quite yet known. So to the questions that the mom is specifically asking for her son, so as we discussed it, assuming that the son has had plenty of exposures to traditional half-life products, then our expectation is there really wouldn't be a significant risk of inhibitor. So that should be safe and reasonable to use, and of course would be, if that's the product that the family felt would be most appropriate, then by all means.
It doesn't state here in the question, but how much does family history of hemophilia and specifically of inhibitor development influence that conversation with families who are in a similar spot to the person asking this question here?
Of course, family history plays a very significant role, and if there was a family history of inhibitors going back in different generations, then I think that would certainly give people a lot of pause to say, well, what would ultimately be the best choice? And I think that's where we have to consider standard half-life products, extended half-life products versus potentially plasma products in that scenario, given that there is some data to suggest that plasma products may be more beneficial from a standpoint of preventing inhibitors. So that's certainly a good conversation to have with the HTC, and I think it all depends on on the bigger picture and what the family may be familiar with and used to, and having that conversation about those three different options.
Excellent. Our next question comes from a blood sister living in Australia, actually, and her question is, how as a clinician do you assist young patients and their families and help them prepare for the onset of a woman's menstrual cycle? She says, I've noticed a lot of uncertainty from moms, especially in groups lately, around how to prepare their daughters. I don't know how many female bleeders you treat, but curious to hear your answer to that question.
So we certainly have, plenty of women who are carriers who do have lower factor VIII levels. And of course, I think this could have some applicability to other bleeding disorders. For example, von Willebrand disease would be a very good example for where this would be very common. So I think the first thing that's very helpful and what we counsel people is that as a general rule, and of course there are always exceptions, that the pattern of bleeding in terms of when does it typically start, how severe is it initially, tends to be somewhat familial, that oftentimes we can see patterns emerge in different families. Now, that being said, someone who may have a bleeding disorder might skew the pattern a bit and might have bleeding a little bit early. And then on the flip side, we sometimes see people who may have anatomic issues or other type of problems that may have the onset of bleeding much later. And we can also see that in different hormonal issues as well, or endocrine issues. So having a good sense of the pattern in the family history is a good starting point, and saying, well, women in our family tend to start roughly around this age, and so then being a bit anticipatory of what could be a possible starting point. And then, of course, I think it's really critical to try to make it as normalizing as possible, and emphasizing to young women and girls that this is something that women go through, and they will become experts in, and they'll get used to, that it might be a bit jarring and discomforting at first, but certainly trying to demystify it as much as possible and normalize as much as possible is really critical. So in terms of preparing for the actual onset, of course, the challenge becomes it's hard to predict exactly when, but having some sense of a pattern is important, and talking through it with the young girl is important to kind of say, well, hey, if it does happen and you're at home versus if this does start and you're not at home, what are some action steps that we can take, and having kind of an agreed upon plan for how to approach it. And then, of course, staying in close communication with their doc or with their hematologist to get a sense of, well, if it were to start, making sure that there's good monitoring, that there's a plan ahead of time to sort of keep track of the degree of bleeding, and then, of course, being prepared to intervene with a number of different potential products, whether it's antifibrinolytics, whether it's working in conjunction with an OBGYN, and potentially considering hormonal contraceptive therapy. And then, of course, depending on the specific blood disorder, using the factor product or whatever other appropriate products may be indicated based on the diagnosis. So there are several different layers to that. To briefly recap, I think first would be get some sense of family history, and that way have a little bit of ability to predict, knowing that if there's a bleeding disorder, it might happen a little bit earlier than the typical pattern in the family. Making sure to normalize and demystify as much as possible. And then, of course, having some action steps for whether it were to occur at home versus whether the child were at school or maybe out of the home environment, and how to approach it. And then keeping good communication with their hematologist so that medications are ready and that it's been discussed ahead of time. And so, it's known, well, here's our plan, here's what we could potentially order or prescribe, and here's how we can monitor and follow up to make sure that the bleeding is slowing down, that the child is tolerating it okay and is dealing with it well. And, of course, in the event that the bleeding is severe, making sure that hemoglobin is being monitored and that it's not causing an acute anemia. So I think those would be good steps to really prepare and hopefully deal with it as efficiently and easily as possible.
Our next question comes from an adult blood brother who is in California, like you and I are. As a person with severe hemophilia B, I am hearing a lot about the current gene therapy trials that exist. Can you please shed some light on the differences and similarities in these studies? Which seem the most promising, most novel, least invasive? What are the pros and cons of participating in the trial? And are there any studies thus far, if one is on long-lasting, and how that trial is going? So are there any, hard data thus far from these gene therapy trials of people with hemophilia B that you could refer to as well? So what is your response to this individual?
So it's an excellent question, and it certainly speaks to the future quite a bit. So the person asking the question is very correct in that there are a lot of gene therapy trials specifically for hemophilia B. And for those who may wonder, well, why in hemophilia B versus not quite yet in hemophilia A, or why is it not as popular or happening as often? And the key challenge comes down to essentially the size of the gene that produces the molecule. And the hemophilia B gene is smaller and is a little bit more easier to replicate and deal with in a lab scenario than, say, the hemophilia A gene, which is larger and a bit more complex. But of course, as the techniques are being refined and studied in hemophilia B and the ability to deal with increasingly complex genes, then of course this will translate over to hemophilia A. So in terms of what are the key differences, the ultimate theme for all of these trials is essentially using a virus vector is the term used. So essentially a gene that would function at a higher level than the native gene in the person to provide a higher level of factor expression is coupled with the virus, and the virus is given to the patient, oftentimes just through an IV, and essentially the virus then makes its way towards the liver and works to create new factor production and essentially tries to override the endogenous gene that the patient was born with. So that's sort of the theme across all of the gene therapy trials, and they're all right around that, right around that game plan. And that goes for other types of diseases as well, for example, sickle cell disease. So that's essentially how they work in the most basic nutshell. So certainly the trials seem promising, and particularly in some of the earlier animal models, they found that the factor expression was right around upper 20s or 30% or so, and lasted for a very long time. The challenge, of course, in the human trials has been that it's only been a very small number of people, so it's hard to draw really concrete conclusions, but it appears that the factor expression maintained in that 20 to 30-ish% range and lasted for approximately a year, and then we start to see a decrease in the factor VIII level shortly afterwards. And oftentimes, some of those people may go back to where they originally were. And why exactly that happens is a little unclear. There's been some theory that it may be essentially rejection, if you will, of the new gene with the virus, and that the host's immune system starts to fight back because it is considered quote-unquote foreign to the body. So that is one of the current really active areas of research to get a sense of how can we extend the level of benefit. So, of course, there are a number of pros and cons to participating in any clinical trial. And, of course, the critical thing is making sure that eligibility criteria are met. So there are usually very strict criteria for who is eligible and who is not. And that's really important to make sure those safety standards are in place, especially for something so cutting edge and so incredibly new to the world. So there certainly are many studies that are available, and I would encourage people to go to ClinicalTrials.gov. And this is an arm of the National Institutes of Health website where one can just simply type in, say, hemophilia and gene therapy, and it'll bring up a list of all the studies that are available. And as one goes through that list, they'll see that it's all relatively similar. It tends to be a virus that's used as a vector to introduce a differently functioning gene that will provide a higher level of factor expression. And then under each description for each specific study, they will list, what are the criteria that are available and who would be eligible and who wouldn't. And so that's certainly a wonderful resource to get a sense of what are the options to potentially participate in. As far as any studies looking at whether someone is on one of the newer, longer-lasting products and doing a trial, to my knowledge, I'm not exactly sure that there's one that's definitively looking at that. But then again, when one goes through the eligibility criteria for a lot of these studies, it doesn't seem that is something that would be an exclusion. So meaning whether someone is on a standard acting product or an extended half-life product, they still would be technically eligible to potentially participate in one of these trials. So if someone really does have interest and wants to pursue it further, I would certainly encourage them to talk with their doctor and set up an appointment to specifically talk about this, whether over the phone or in person. And then, of course, I would encourage people to use ClinicalTrials.gov. Just type in hemophilia and gene therapy under the search bar, and then take a look at where some of these studies are available, what the different criteria are for who would be eligible and who would be excluded. And if interested, certainly could go from there and work with their doc to contact the study sponsors to see if they're still recruiting patients.
Excellent. And we have a link to ClinicalTrials.gov in the program notes for this episode, so you can click just in the description box of this episode if you'd like to check out ClinicalTrials.gov. The next question is one that I relate to pretty closely. It comes from a man in his late 20s on the other side of the country in New York who is living with hemophilia, and he says the following. Considering I have experienced some recent need in addressing aging/damaged joints, do you think there's a different level of damage that comes from blunt force as opposed to spontaneous bleeds? And what would be your 20-year outlook for improvements in joint replacement or alternative therapies such as stem cell research for the future of people with bleeding disorders? How would you respond to that?
Oh, sure. So again, another really interesting question, and I think speaks to some current challenges and definitely some cutting-edge future therapies that are on the horizon. So to the first part of the question, whether there's a difference between damage that comes from, quote, blunt force as opposed to spontaneous bleeds, and the answer is that likely there is a difference. It also, as always in life, kind of depends on some of the specific circumstances, but I think one of the key distinguishing aspects would be if an induced bleed or traumatic bleed that occurs as a part of blunt force or some sort of specific trauma or injury, then I think part of the challenge becomes what other structures may have also been damaged. For example, was there bony damage as a part of of the trauma or the blunt force? Was there damage to any of the tendinous structures or ligaments that might be a part of that joint, as opposed to just spontaneous bleed? So if there was a degree of damage or sprain or in a more severe form, tear or break of either a soft tissue like a tendon, ligament, or a break in something like a bone, then certainly that would likely cause a more complex degree of healing that's necessary and may potentially predispose to earlier and longer-lasting joint issues on top of the risk of potential other spontaneous bleeds into an already damaged joint. So that is a bit of a rambling answer, but certainly I think the key aspect to drill down to that question would be what, if any, damage occurred to any other parts of the joint as a result of the blunt force or as a result of the trauma. Whereas we know that whether the bleed was induced by trauma or whether it was spontaneous, there's certainly the concern of inflammation that comes with having blood in a joint space where blood's really not supposed to be in a joint space. And then, of course, the blood itself can be irritating or damaging to the lining of the joint as well as some of the other structures that may be in there. For example, let's say it were a knee where the ligaments traverse. That would be certainly concern for agitation directly from blood components as those blood cells break down and release all of their salts and other intracellular components. And then, of course, the inflammation that comes with bleeding, because certainly bleeding brings white blood cells and platelets and different immune proteins that are in the plasma. And so as the whole blood gets into the joint, there are a couple other aspects that alone would certainly agitate and irritate a joint. So in terms of the question of what would be the 20-year outlook for improvements in joint replacement, so certainly I think the outlook is very positive. We've seen over the past few years a lot of advancements on the engineering side of medicine where the technology for prostheses continues to advance and the surgical techniques for either joint replacement or other intermediate type surgeries continue to get better, continue to become less invasive, and those techniques continue to refine. So then there's the question of, well, what about stem cell research for the future of people with bleeding disorders? And I think that can be taken in a couple different ways. I think one could look at it more of a local or type issue. So, for example, let's say someone had a very severe knee, and the thought was, well, what would be surgical options versus medical options, and would there be an opportunity for stem cell research locally? And so there has been some pioneering research looking at specific types of stem cells. They're called mesenchymal stem cells, and their job is to mainly help produce new connective tissue. So essentially things like tendons, ligaments, all of that would be kind of the structure of the joint. And so, interestingly enough, a lot of that research has been pioneered in athletes and of course, in older adults who have issues with osteoarthritis or long-standing chronic use injuries, where they're finding that you can have some improvement, and this is an exciting area to essentially start to rebuild the joint a little bit and make it a little bit, make it function a little bit newer, if you will. So certainly there's that opportunity. In terms of stem cell research in general for patients with bleeding disorders, so more of a global stem cell reboot, that is a bit of a backseat as more targeted therapy such as gene therapy is thought to be the way to go, where there are less sort of overall complications. In a pure stem cell transplant, there's the need for a great degree of immune suppression, and there are a lot of risks for infection and so forth around that time. So I think the hope is that stem cells can really start to become a bit more targeted. One could say, well, we want to specifically induce stem cells to help rebuild or regenerate parts of a joint internally. I think that would be ideal to more of a global stem cell approach. And then, of course, the global stem cell approach is likely to be supplanted by gene therapy. If we can be more specific, more targeted to just raise the expression of the factor VIII or whichever factor protein, then that would be preferable to a larger scale stem cell transplant. So hopefully that answers the young man's question specifically, but ultimately there are a lot of great advances, both from a standpoint of regeneration of tissues as well as the advancement of prostheses in our colleagues with engineering. So certainly exciting times, and I think we'll continue to see more of that information come out.
So going a little further down the road on joint damage and what a guy with hemophilia experiences over the course of his life, the next question comes from an adult male in his middle age. He's originally from India, but now living in the United States. And his question is the following. There's a real fear of infection in my right knee if I now opt for a total knee replacement, which is decades overdue. I am immunosuppressed due to a kidney transplant. What are the best options for my knee? We also received this question from a separate individual, but he says, what can I do at my age of 56 to help keep my joints strong so that I don't have joint bleed? So both questions dealing with considerations of fellas in their middle age want a total knee replacement with that added consideration of being immunosuppressed, and the other fellow just kind of generally asking how at his advanced age for someone with hemophilia can he keep up his joint health. How would you respond to those questions?
Oh, so both great questions. So the question about, what can I do at my age of 56 to help keep my joints strong so that I don't have joint bleed? Admittedly, I think this is something that the advice can be a bit universal and would certainly be good for any age. I think first and foremost would be, working with the doctor team to find potentially a prophylaxis regimen that meets the needs of that individual. And I think that's a real strength of what is happening in the hemophilia community, which is serving as a model for a lot of other types of medicine where trying to individualize medicine. So I think for that individual, for any individual, whether it's a teenager playing sports or a young adult or a middle-aged adult, or really at any age, I think the key would be having a good sense of what activity level they would like to pursue or achieve, and then working with their physical therapists and their docs and the nurses to get a sense of, well, how can we tailor factor replacement to try to prevent? And then, of course, what are some good exercises to help maintain joint strength? And this is where a real strength of our physical therapists at the HTC can provide great advice to any individual about good strengthening exercises, particularly non-weight-bearing types of exercises that will help strengthen all of the components of the joint, and then also try to help prevent bleeding as well by trying to minimize the amount of blunt force, as the previous gentleman asked, or the amount of trauma that one may get from repetitive weight bearing if it's used in a more physical manner. So I think that would be the key thing for anyone is one, work with their HTC and with their care team to get a good sense of what would be recommended from a standpoint of prophylaxis versus would there be aspects of situational prophylaxis. For example, if someone were to pursue a certain endeavor, let's say run a half marathon or something, and they really wanted to go for it, well, how could they potentially do prophylaxis around that time? And then, of course, having a good sense of activities for non-weight bearing as well for strength and toning and maintaining their joints as all of us age. So I would really say that that's a great question, and the best way to get at that would be to individualize it and set up a time to work with their team to really address every one of those aspects, looking at individualized levels of factor, pre- and post-factor infusions to really make sure that it's tailored to the specific individual, and then working with their nurses and physical therapists to get a good regimen of different types of exercises, both weight-bearing and non-weight-bearing, that they can use to make sure that they keep joints and their body healthy and strong. So as we shift towards the first question to the person who asked specifically about potentially needing a total knee replacement, but also having the extra layer of a challenge with being immune suppressed from a kidney transplant. So this one, of course, is very challenging and speaks to a very individualized question. I think first and foremost, if it's really felt by the patient and, of course, by the care team they work with, both the medical team as well as the surgical team, that a total knee replacement is truly the best and most appropriate option at this point in time, meaning that they've exhausted all medical avenues, whether it was particular types of rehab or potentially other assist devices. Then I think the challenge becomes, making sure to commit to that plan and having everybody on board. So this extra layer of challenge with being immune suppressed from a kidney transplant, certainly we see plenty of patients who are immune suppressed for a number of different reasons, whether it were kidney transplant or stem cell transplant, as we briefly alluded to earlier. So surgeries, any type of surgery in that patient population can be done and happens on a routine basis throughout the world. So I think the critical piece is working with the local infectious disease team to get a sense of what degree, if any, of prophylaxis would be needed from an infection standpoint. So potentially prophylactic antibiotics could be used around the time of the surgery. And then, of course, making sure that there's a close follow-up plan and what will be the monitoring plan for immediately after the surgery in the hospital, and then what would be the monitoring plan for afterwards, and then making sure there's really good education with the surgeon as well as the infectious disease team about what signs and symptoms to look for and how they could immediately manage a suspected infection right away. So certainly Certainly it's hard to give very specific answers beyond that, but what I would encourage this individual or anyone else in that similar time frame is to make sure that, have time to talk to their hematology care team, figure out which surgeons, which surgical group that their team would recommend, or perhaps there's a surgical group that they've worked with a little more frequently that has experience with folks with bleeding disorders. And then from a standpoint of the immune suppression, making sure to work with presumably their nephrologist or their transplant surgeon, as well as infectious disease doctors, to say, well, what would be our plan for prophylaxis? What would be our plan for treating a suspected infection, and making sure all of those possible scenarios are thought through ahead of time, and that those letters are written and those plans are in place so that when things happen, they can be responded to in real time, as opposed to scrambling to arrange the right players, while there's immediate suspicion of an infection. So I think as long as the thinking and the research has been done ahead of time to put those plans in place, and if the surgery is felt to be the best approach by the patient as well as the medical and surgical teams, then it's certainly something that can be done and happens on a regular basis.
Excellent. And to wrap up here, final question for you. And admittedly, this is a question that might be best designed for a social worker at the HTC, but I'm sure you have some insight to provide. The question specifically is, are most insurance companies allowing patients to switch from an older product to a new product without a fight? And I think that also kind of gets at a larger concern that many in the community have about the insurance climate and the changing healthcare climate and how that may affect access and affordability for patients who want to try some of the newer therapies or don't feel as though that their current regimen is optimized for their individual self, as you were talking earlier about the trend toward individualizing care. So how would you specifically respond to this question about that switch from an older product to a newer product? And then in general, how has it been interacting with insurance companies as the hemophilia world is rapidly growing and evolving?
Well, it's certainly a great question that I think a lot of people share, and I think it speaks to, as you nicely said, sort of the insurance climate is a bit unclear. How is it going to change on a national landscape? How could it potentially change on any individual statewide landscape? And that it's certainly something that's causing a lot of concern for many people, patients, families, nurses, social workers, physicians, all of us, I think, share that concern. So very generically, what we're finding is that for the most part, that being able to switch from an older product to a newer product, and particularly the extended half-life product, that those switches have been going relatively smoothly. That oftentimes a prior authorization may be required depending on the specific type of insurance, but that is something that the social workers and the case managers and the nurses and the docs throughout the HTCs, as well as any physician group, will be familiar with. That's something that's common for across the board in medicine, and of course hemophilia and hematology is right up there with those needs. So generically, we found that for the most part, it's going smoothly. I think the key thing would be working with the individual doc and individual social worker and nurse and with their hematology team to get a sense of how has it worked for their specific office, and then trying to get a sense of, in any individual office, have they found any significant differences between the types of insurance, whether it's more of a private payer or a government-based payer, whether that's local or state or federal. So having that discussion ahead of time is always very helpful. And then getting a sense of what, if anything, is required or needed up front. Is a prior authorization needed up front? And if so, that is something that should be relatively straightforward, where all physicians are used to writing letters or sometimes having to do one-on-one discussions with insurance company representatives. So I think that the key thing is good communication, as you nicely said, with the social workers and with the case managers, and just getting a sense of what their experience has been with that specific insurance type, and then being prepared. And I think there's no substitute for being prepared ahead of time and planning this ahead of time and anticipating what the needs may be with the individual insurance company. But that being said, certainly I think all of us are anxiously watching the insurance climate from a bigger picture standpoint, and until any concrete changes are made, it's hard to speak to what, if any, different approaches would be necessary. But certainly I think, especially in the hematology world and with hemophilia, that our folks are very in tune to this need, and that it's a very active time where there's going to be a lot of a lot of changing of products. So I think a lot of the HTCs will be gearing up to be prepared for that and have already gotten their feet wet with the switches to extended half-life. So I think generically it's mostly going well, but the critical thing would be work specifically with a social worker and or case manager and find out what the specific needs for any one insurance plan is, and then go from there, and then hopefully the care team will be diligent about getting any necessary letters or any paperwork to make that transition go as smoothly as possible.
Thank you very much for your time today, Dr. Arash Mahajaran. Sincerely appreciate it. Great answers. And again, just thank you for making the time to consider these questions and give such thoughtful responses. I'm sure the community really appreciates it.
Oh, my pleasure, and really thank you to you guys with the Bloodstream podcast. I mean, I think this is an excellent resource, and I really hope families and patients and HTC folks are listening and hopefully will continue to participate.
Yes, I would love to have you back on to answer future questions as well.
Oh, sure. Thank you.
Thank you. I'd like to thank Dr. Arash Mahajaran for his expert responses to our listeners' questions. Check out the program notes for this episode in the description box or on bloodstreampod.com for links to resources and information relevant to today's episode. Thanks as well to everybody who submitted questions for Ask the Expert. I personally appreciate it and hope that you have gained from listening to this episode. Reminder that you can submit a question to Ask the Expert by posting to our Facebook page, facebook.com/bloodstreampod, via Twitter @bloodstreaminfo, or emailing mailbag@bloodstreampod.com. And don't forget to subscribe to Bloodstream on iTunes, Stitcher, or wherever it is that you listen to podcasts. Our next Ask the Expert episode will go live at the end of February. Make sure to submit your questions and stay connected to Bloodstream on social media for announcements about future Ask the Expert guests and other info of interest. Reminder to check out Bloodstream's monthly flagship episode at bloodstreampod.com. And by the way, the January episode features my conversation about football and finance with NFL Super Bowl champion and hemophilia advocate Josh Gordy. Again, available at bloodstreampod.com. Thank you to the team at Believe Limited for making today's episode possible. My name is Patrick James Lynch, and until next time, take self-care of yourself.